بسم الله الرحمن الرحيم. Bismillah ar-Rahman ar-Rahim. We are going to start the second session. It's a pleasure to co-chair this session with my dear colleagues, Professor Dr. Tariq Abdel Gawab, Dr. Samia Sobhi, Dr. Ghada Ged, and I would like to express my gratitude to the organizing committee, Professor Dr. Hisham Awad, Dr. Safa Shafiq, the enthusiastic Dr. Rania Al-Farraj, our dear sweet Dr. Rania Ibrahim, and all the organizing committee. And I'm happy and membership. It is a delayed membership with Intensive Care Organization Association of Neonatology, Ain Shams. We are all belonging to Ain Shams University, and it was really a pleasure to be a member and to be announced this year for the association. Let's start with our first talk.
First of all, I have to thank Professor Dr. Hisham Awad and the organizing committee to invite me for this fantastic conference. I wish you a great progress, a great success in the next years. Our first speaker is Dr. Julian Eason, consultant neonatology, chief of neonatology department, Cornish Hospital in UK and Abu Dhabi. He will give us a talk about seizures and cerebral function monitoring.
Thanks very much indeed, Chairman and organisers. And once again, thank you for the opportunity to talk to you and give you an insight into my views and how we look after babies with neonatal seizures. So I'm sorry you're hearing my voice again, and you'll have to hear it again because I have a third talk today as well on neuroprotection. So let's start with neonatal seizures. And I'm aware we have some very eminent people in the audience who probably know more about neonatal seizures than I do. But the main reason I talk about things is simply as a practical neonatologist running an NICU that is a very, very busy. Seizures is very common to us all. And I'm sure we all, once again, probably treat these babies slightly differently and all have different approaches to them. And it's very hard to find out exactly what is right to do, but I'll try and give you an insight into my understanding and what I do as a neonatologist and how I move forward with this. So we're just going to look a little bit at definition, types, causes, how these babies can present, a little bit about investigation, treatment, EEG, a very small bit on CFAM, and then a website that's probably worth writing down because it's a good educational website that's been developed by Dennis Azzopardi, who you might know from Imperial College, who was very intimately involved in the Toby trial, and is quite a good free educational resource on the neoweb.org. And I'm all for free education. I don't mean to insult your intelligence, but ordinarily a seizure, Volpi's definition in '89, a sudden paroxysmal depolarization of a group of neurons that results in transient alteration in a neurological state. And it can be motor, sensory, or autonomic, and your conscious level may or may not change. And sometimes that isn't always difficult to define in some of our very small babies. So incidences varies, once again, depending on which text you read, but at 1 to 3 per 1,000 live births. Premature infants, which is what we all deal with a lot of the time, as well as our term infants, are at a higher risk. And what's interesting is that the vast majority of neonatal seizures will appear very early on. And that's helpful because that means they're usually under our care. So not too much on the biochemistry and the science, but ordinarily we're dealing with a sodium-potassium pump in the neurons that can be depolarized and hyperpolarized. And essentially we have excitatory glutamate which will excite a neuron, and we have inhibitory GABA, which inhibits the excitation. So if you have excess glutamate, you will overstimulate one of the neurons, and if you lose your GABA, then you will prevent your inhibition of the sodium potassium pumps. And therefore, these processes and various medications and polarization and depolarization of the postsynaptic neuron is essentially why neurons will start firing off and perhaps eliciting in visible, not always visible, but seizure activity. And that is essentially a very relatively straightforward mechanism that we're thinking about or dealing with most of the time. Seizures, they're hard. Subtle seizures. What does subtle mean? Subtle means, did we see them? Was it really a seizure? Am I convinced something is a seizure? I think there is no doubt in anyone's mind that they're quite hard to define in many, many cases. And in fact, subtle seizures are said to be very common in premature infants. And you can have EEG changes, but actually you don't have to have EEG changes, and that can be quite tricky, because when a baby is sucking or mouthing or chewing or lip smacking or smiling, I have various doctors or various nurses will say, my baby's sucking on the baby might have had HIE, might have had something, and therefore when this baby sucks on the tube, it's automatically a seizure, because the baby shouldn't be sucking on the tube. But in actual fact, a number of studies have shown that sucking on the tube is probably unlikely to be a seizure, less likely to be a seizure rather than more likely to be a seizure. And yet we will interpret a repetitive movement quite often as a seizure, particularly if a baby has had some sort of insult, major or minor. So very, very hard to interpret. Blinking, fluttering, staring, cycling, arm movements, alteration in heart rate, blood pressure, hiccups, apnea, color change, all things that actually happen in our premature babies almost every single day. When do we then say this is seizure? And how do we convince ourselves that this is something that we need to do something about? Because I guarantee you, and I don't have them for you today, but you've probably seen videos where someone will show you a baby doing a movement and they ask you, seizure or no seizure? And half of you say yes, and half of you say no. And the fact is that's the way it is. We're usually right about 50% of the time. Now, some of us might think we're a little bit better than that. Some of us may not. But it is very hard in neonatology, particularly to define a seizure. Clonic seizures, true clonic seizures, the incidence is still relatively high. And many clonic seizures are associated with the EEG changes, so not all. Repetitive jerking, moving one side of the body or one limb, rhythmic movements is often slow, 1 or 3 movements a second. So those clonic seizures we certainly see, and the vast majority of the time they will classically look like a seizure, but once again, not always, when you investigate them, associated with EEG changes. So, is it a seizure? Tonic seizures are much less common. About 5% in our preterm population, usually associated with EEG changes if they're focal tonic, but generalized tonic may not be associated with EEG change. So the examples are sustained posturing, deviation of the head or the eyes, and generalized tonic seizures can mimic decerebrate or decorticate posturing. So you've got your decerebrate, upper brainstem lesions, and then you've got your decorticate, damage to your cortical spinal tract. So not classical positions we see the babies in, but because it is not that common, but they do occur. Myoclonic seizures, perhaps we see a bit more commonly. So focal and multifocal myoclonic seizures, often not associated with EEG changes, but generalized myoclonic seizures are. These can be rapid, isolated jerks, common in the flexor groups of muscles. But there are various subtypes. There can be certainly just one extremity. They can be generalized. They can be axial. So myoclonic seizures certainly we see. What else can these seizures be? Or what else can myoclonus be? And we often have the word jitteriness. So what is jitteriness? Well, it's a tremulous type of movement, normally not associated with any autonomic change or ocular changes. It can be stimulus sensitive and ordinarily is said to stop when you touch the limb. So this is where we would see a baby making some sort of movement. Is it jitteriness or is it myoclonus? Touch the baby, everything stops. We seem to convince ourselves, oh, that this is jitteriness. It occurs very commonly in premature babies. We see a lot of these tremulous movements, but it can also be associated with other conditions. And so we always have to have in our mind, in our background, that jitteriness can simply have causes. It may not be a seizure as such, but it can be associated with other parameters that we need to ensure the baby isn't suffering from. Benign sleep myoclonus, the bilateral repetitive myoclonic movements that you see during sleep. Well, these are very common. Many of you or I may suffer from that, we often see sleep myoclonus. The EEG is normal. It tends to resolve spontaneously, but can happen at any time. And hypereplexia is basically the exaggerated startle response, and we can see that in a lot of our babies who are very, very sensitive, where they suddenly have this very, very exaggerated response. It is actually a normal phenomenon and ordinarily simply requires reassurance. But once again, you wouldn't reassure somebody that everything's normal until you've had a bigger look at the baby and perhaps understand a little bit more about the story, the history, medication, and perhaps some blood work. So if I look about jitteriness versus seizures, is there any better distinction to make? Well, jitteriness can be provoked by stimulating or stretching a joint. You can stretch a joint and it can become very, very jittery, whereas seizures ordinarily would happen spontaneously. There's no obvious stimulation for it to be caused. These can be stopped. Passive flexion or gentle restraint ordinarily, never 100%, we are talking about medicine here, ordinarily will stop jitteriness, but it won't stop a seizure unless that seizure was due to cease at that period of time that you gave some gentle restraint. These are rhythmic oscillation, and there are fast and slow components in seizures. Frequency of jerks is said to be a bit faster, 5 to 6 per second as opposed to 2 to 3 per second. Abnormal gaze in the eyes, nothing happens with the eyes in jitteriness. It can certainly do so in seizures. There's no autonomic disturbance in jitteriness. It certainly can occur in seizures. And the EEG ordinarily would be normal, whereas you would expect an EEG to be abnormal with seizures. So there are distinctions to be made, and when they're thought about, ask those questions, and you can usually distinguish between the two. So what's the etiology of the reason that our babies are having seizures on the NICU? And it isn't all HIE or neonatal encephalopathy if it isn't hypoxic, but that is a reasonable part of our work. And I don't know. I'm a little bit bemused in Abu Dhabi and in my hospital, in that I work in a hospital that's a major referral centre, has had a very large amount of deliveries, far more than the hospital I came from when I was working in the UK. But I see less neonatal encephalopathy, HIE, in Abu Dhabi than I saw in the UK. And I'm not sure I can quite understand it, except that I'm delighted. But when it comes to therapeutic hypothermia for babies with true HIE, I do less in Abu Dhabi than I was looking after in the UK in a smaller unit. And I'm not sure I understand why. And I know for a fact I'm not missing them. So there's something good. I wish I knew what that good bit was. But I'm not quite sure. I'd be interested to know your rates of HIE and what you see. Whether that's an isolated phenomenon in my hospital, I don't know. Anyway, it's still a reasonable cause for seizures. Cerebral, we're talking a little bit about that now. Cerebral arteriovenous infarction, so stroke. We see sinus thrombosis is a reasonable cause of seizures, depending on the timing of that event. So if it occurs close to delivery, a baby can still be in shock and seizure. If it occurred a month or two ago in utero, then the babies are often on the way to recovery and can be much less subtle. In fact, some babies can have a stroke and come out and it is as if nothing has ever happened. And we know that's the case because if you do a CT or an MRI on some 2, 3 or 4-year-olds, you can see that they have had a middle cerebral artery infarct at some stage, but you never knew about it. They were normal at birth and their development is normal. So something happened in utero that you didn't then data detect. So we know this can be symptom-free, depending on the timing of occurrence. Intracranial hemorrhage, we know, is a cause, and we've talked about that. No matter where that bleed is, a cause of seizure. Infection, yes, of course. And the last thing we want is bacterial meningitis, viral encephalitis, obviously very nasty. Any meningitis is going to be a problem, or intrauterine infections with CMV or toxo is a possibility. Metabolic, well, yes, I think we all know about hypoglycemia and hypocalcemia, and it's a bit of a reflex for us to keep an eye on that in babies because it can precipitate. When you are deficient in these, then that sodium-potassium ATP pump will be affected, and therefore you can increase excitation when you have problems with calcium and sugar, therefore firing off the postsynaptic neurons. Congenital cerebral anomalies, of course, we all see babies with congenital malformations. And that can be many, many different types of conditions. And then there are some we just don't really know why a baby's had a fit. So we have a lot of reasons that babies can have seizures. I thought I'd just mention hypoglycemia a bit because it is so common. And in actual fact, although most are diagnosing it now at a level below 2.6, if you go back through the literature, to actually, the levels that people have felt hypoglycemia was a problem to baby has changed over many, many years. That level has not always been 2.6, it has been 2.2, it has been 1.8. It depends which journal and what year you read it that people have a concern. And we know term babies in the first few hours are often well below 2.6, and that's entirely normal. So the definition of hypoglycemia is a little bit not always easy. But we know in our LGA babies and our SGA babies, they're going to be far more prone to that. And therefore, associated seizures can occur with hypoglycemia. And there are concerns about the problem. So we know that our diabetic mothers, now don't know about what's happening here in Egypt, but gestational diabetes in the UAE is frighteningly high. A very, very high number of our mums are diabetic, and more are becoming so. And we can all have another talk and postulate as to what is happening with the population. But a lot of our mums are diabetic, and therefore we're going to have we have a lot of problems with hypoglycemia post-delivery. Other medical conditions, of course, that increase the utilization of glucose can be causes, and therefore this is a whole investigation into itself as to why you may be hypoglycemic, particularly if it manifests itself in a seizure. But seizures aren't always the commonest thing that occur. You can once again have this jitteriness. You can be completely asymptomatic, as you know. So once again, whenever our babies elicit symptoms, we've just really got to start, because they can't tell you, because they can't talk to you, we do have to begin a whole series of investigations to try and work out the causes. I don't know about you, but ordinarily there are different ways of treating, but ordinarily most of us will try and correct a symptomatic hypoglycemic baby relatively quickly. And I've always thought this was an interesting range, 2 to 5 mils, because if you give a very large dose of sugar, of course, we know you get rebound hypoglycemia. So some of my colleagues would certainly never give 5 mils per kilo. Some would only ever give 2, and we have little arguments about that, and you may have your own views on that. But ordinarily, you don't want a sugar bouncing up and down. But it's something that we need to treat. And then, of course, we have other medications that we can all go down the line and go into the whole world of hypoglycemia and the treatment of how that may be worked up. But there's no doubt in some babies it can persist, and when it does persist, we then need to start working these babies up, just trying to work out if there is a reason for these infants to have continued hypoglycemia. In fact, the commonest reason that I saw babies requiring these workups because the problem persisted, actually they resolved after a month, and the diagnosis at the end of the day was persisting hypoglycemia idiopathic persisting hypoglycemia, which resolved. And so it took a month to resolve with all these tests coming back as normal. And so many babies can actually continue to be hypoglycemic and still not have anything physically that you're going to find or diagnose them with, and they do recover. As we continue with our causes of what might cause a baby to seize, hypomagnesemia, hypo or hyponatremia, drug withdrawal, not something ordinarily that I've seen a great deal of in the UAE. However, we now do have a chronic pain clinic, and some of our mothers are on prescription morphine at quite high doses. And so we've had 1 or 2 babies with drug withdrawal. Now in the UK I would see much more drug withdrawal and babies becoming jittery and sometimes having seizures. And in fact, and when I worked in Canada, I saw wards and wards of babies with having drug withdrawal, but it's not something I see commonly in the UAE. Inborn errors of metabolism, of course, I'm seeing these because of we have a number of genetic issues, multiple relations and first cousin marriages, and so we do see a lot of infants with inborn errors. Neurocutaneous syndromes, of course, and other epilepsy syndromes, which are of note. Benign idiopathic neonatal seizures, benign familial neonatal convulsions, early myoclonic encephalopathy, early infantile epileptic encephalopathy. So the list is almost endless when a baby has a seizure, when we start to try and find out why. Let's talk about benign neonatal seizure syndromes, because if they're benign, it's very, very reassuring to the family that it's benign. And if you can be confident, if we can ever be confident, then it's it instills a little bit more calm into the care. So benign familial ordinarily in the first 2 to 3 days of life, and then disappear by 2 to 6 months. With a family history usually, but not always, and normal development. So it's a diagnosis of exclusion, yes, because you don't just rush in and say, oh, by the way, this is benign, but this is the pattern. And if you end up with this story and end up with this, it's a very good diagnosis to have. The benign idiopathic seizures, or what we used to call fifth-day fits, which actually often happen on day 2 or day 4 or day 7, but they're known as fifth-day fits. These are multifocal fits, and in actual fact, resolve relatively quickly. All investigations are normal, and they just don't seem to come back again. And the retrospective diagnosis, that was benign fifth-day fits. Another nice diagnosis to have. Benign sleep myoclonus, I think, is incredibly common. We see it a lot. Very benign rhythmic movements which occur during sleep that can mimic seizures. And they may occur focally during non-REM sleep. Video EEG shows no electrographic seizures. So when you see benign sleep myoclonus, it can be incredibly exaggerated in the premature infant. And you can be convinced this is seizure activity. And really, video EEG plays a very important part of this, because it's very hard to convince. There are many because seizure is often a description, that what's changed in, once again, I go back, what's changed in my life is parents now coming in with a video of what's happening on their telephone. Now, we didn't have that 20, 30 years ago. We just simply didn't have that information, and we took the history from the family of what they were telling us was happening, because the vast majority of pediatric neurologists never witnessed a fit that they're giving very, very toxic medication to the child. And we know that many children are on toxic medication that don't need to be on it. So we're lucky in the NICU in that we can get more frequent witnessing, and with the advent of the telephone and quick selfies, if you like those too, we can see what a baby's doing, and this can be very, very helpful. So although I'm not saying that's part of a diagnosis, that's not something that should be routine practice, I think sometimes to actually see what people are describing is far better than listening to the description. So I think that's where mobile phones have been very good. We haven't yet banned them in our unit. We are worried about them with infection, but we are allowed to bring mobile phones into my unit. Maybe that's not a good thing, I don't know. For me, it's still all about history. One of the things that I suppose that I guess my children are 20, but my boys are 20 years old, and they still call me Victorian Dad. I'm a bit old-fashioned, and I'm very old-fashioned when it comes to medicine, is I just don't think you can do anything out of the history. I can't stand it when I'm presenting a condition and I ask somebody what they'd like to do and they want an MRI as the first thing they answer. Because I think we do so many tests that are absolutely unnecessary. I think tests should be targeted. And I just don't think we should ever forget the history. And I normally go back. If I talk to my doctors about a mother that's come and I say, tell me about the mum, tell me about her history. Because it's not automatically, electronically transferred to our neonatal history, they often don't know. And so much you need to talk to the parents, so much information you need to know about the family. I have found with our electronic way that we now have neonatal electronic records, our system doesn't bring over the maternal. And therefore, this is missing, completely missing. And I say on the ward round, well, tell me about the mother. Oh, well, we haven't got her record. We'll go and find her record, go and get her record, and let's get the proper history so we can actually begin to make the right diagnosis. That's why my children call me Victorian Dad. It's like going back to school and say, okay, go and do your homework properly, because we want this medical history. We want to know about the mum. We want to know what she's doing. We want to know about her pregnancy history. Sometimes even the delivery history is missing from our notes, and it's so relevant, it's so important, and I'm shocked that it isn't something that should automatically be there. So, once again, call me old-fashioned, but I want to know this, and I want to know the delivery history, and then, of course, the family history. Because in actual fact, from this, you can glean a huge amount of information that I think in today's, certainly in our modern practice in Abu Dhabi, is lacking. Absolutely lacking, and I won't say any more about that. But of course there are tests that you want to do. Tests that, initial investigations that may be relevant. A gas, a glucose, the calcium, the phosphate, the magnesium, routine electrolytes, blood count, blood culture, if you're concerned about infection. There's some routine things. We ordinarily, if we have a baby who's having some seizure activity, would put on a cerebral function monitoring, because that is part of our practice that we have taught. We would consider lumbar puncture. We usually do a cranial ultrasound. So those are kind of initial things, just to say, well, I'm beginning to look at this. I don't know what the reason might be. Or you may already have taken your history and have a very good idea what the reason might be. And you're just targeting some tests and investigations to that. And you will all do this a little bit differently, in a little bit of a different order, but it's a reasonable thing to look at just to give you a baseline. But I'm not a big fan of a whole host of tests straight away, because this sort of thing, metabolic screens, toxicology screens, further difficult formal video EEG. As much as I love a video EEG, I've got to have a very good reason to call my pediatric neurologist over to set one up, because it usually is if I've got a problem with intractable seizures or we need some further assistance with a diagnosis. It isn't the first thing we think of, simply because it's a very difficult resource for us to get. If you have it readily available, then good luck to you, and if you use it, it's very helpful. But I don't use it too early on, and I certainly don't use MRI early on, but we're always going back and making sure we understand maternal serology. So there are certain investigations that you might want to consider when you're dealing with seizure activity. So what's the management? And here this is great fun about neonatologists. We never know what we're doing, do we really? But I think we're quite good at ABC. I think we're pretty good at that. I mean, that's our bread and butter, really. Treat the cause, which we'll come to, and then obviously prevent harm. One of my other things, I think we're very good at causing harm in the NICU. So fit chart. I think fit charts are very helpful, because if you're not witnessing a seizure yourself, but you're just being told about it on a ward round, you want a good description. And I think giving someone the opportunity to write down what they've seen is very helpful. Then we will consider an anticonvulsant with the following. Usually, if I've got prolonged seizures, we're looking at 3 minutes or so, then ordinarily that will initiate the start of an anticonvulsant. If they're frequent, if they're fleeting, but I'm getting more than 3 or so an hour, then we'll consider starting an anticonvulsant. And if it appears to have some autonomic effect and there is cardiorespiratory compromise, we will also consider starting an anticonvulsant. But we certainly don't start an anticonvulsant just the first time a baby looks as if it's had a seizure. That would be the wrong thing to do. We tend to wait and watch, if we can. Why are we treating? Well, I don't know. For those of you who, I remember my days as a pediatrician, and looking after a febrile convulsion was like bread and butter, and kids just fitting all the time with a fever of 39, with a bit of a red ear, a red throat, and then they get better very quickly. And they would fit for 1 minute, 2 minutes, 5 minutes, 10 minutes, sometimes 30 minutes or so. And we were always told, or I was always told, we don't really worry about a child who's fitting unless it's over half an hour, but even then there's no evidence that it causes any harm. That may be the case, and it may be the case in pediatrics, and I don't know. And once again, you can help me know what the current thought process is on childhood convulsions. But in the baby, we do worry about if it's affecting the respiratory system and the baby hyperventilates and blows off the CO2. We do worry, does it have an effect on the brain? We worry about if it has any cardiovascular effects and blood pressure effects. If there are blood pressure and circulatory effects, does it have any effect on the brain? We worry about the energy metabolism. We know it uses ATP. ATP. We know there is an energy usage here. The brain relies on glucose. If your glucose goes down, we worry about the brain. The neurotransmitters, the uptake and release of these neurotransmitters, is there a concern about their effect on the brain? So I think that's why we treat. We have a concern in our very vulnerable preterm infant, perhaps more so than a 3-month-old or an 18-month-old who comes in having its 5th febrile convulsion and it's kind of routine. I don't know if those children have any long-term damage from that. I know they can have a slightly increased risk of longer-term seizure activity, but is it damaging? Well, I think we're worried that it might be. So how do we treat? Here's the fun bit, because everybody does something different once again. I can tell you what we do, I can tell you what I think, and you're free to agree or disagree. That's fine by me, because I can't tell you what's right, because there actually isn't any literature that tells you what's right. We will all have a preference. But I think the vast majority of us start off with phenobarbital, is my understanding. And ordinarily, we will give 20 per kilo, and then sometimes we'll give another 10 or another 20 per kilo. Routinely, I do not start maintenance. We just give phenobarb and we load the baby up. Now, if a baby continues to seize, I put this here, but this is something I don't do. There's a lot of literature that says it's a waste of time. Some people swear by it, some people don't use it, some people try it and then move on to the next. We just don't, we completely avoid phenytoin. We just don't bother anymore. It doesn't appear to make any difference. We tend to go to our very controversial second-line therapy simply because of the evidence of longer-term brain problems with both of these drugs, that none of these drugs, anticonvulsants, are good for your brain. And that's why we don't start maintenance if we can help it, but we would start an infusion of clonazepam if I was continuing to have problems with a baby fitting. That would tend to be our first-line thoughts. So we're a phenobarbital, and then we start an infusion, and we don't use phenytoin anymore. And I didn't use that in my last hospital in the UK either. Some of you may use it, and I know some people do. It's just not something that we use. This was my favorite drug because I love the smell. I love paraldehyde. Wonderful, wonderful drug, but ordinarily not very commonly used nowadays. Given PR, I rather like it. Persistent seizures, some people will routinely start pyridoxine if there's a family history or high risk of pyridoxine deficiency dependent seizures. So sometimes that will be started routinely. And then we have an interesting group of drugs that I see being used invariably in different situations. I was using a bit of topiramate before I came over. Our neurologists love Keppra. They'll give Keppra to any of my babies. If I'm having trouble with controlling seizures, basically, without being too rude, they would ordinarily suggest Keppra. Lignocaine or lidocaine is another drug that is certainly being used in some countries more than others. I just started to use it a little bit more in some of my HIE babies with a bit of caution. And I haven't used topiramate for some while, and I haven't ordinarily used bumetamide. But I would say in varying degrees we would have advice about which drugs to use. There are other drugs that I haven't mentioned that may well be in use as well. These are the common ones that I'm seeing. If I have to monitor, if I have to maintenance, and I'm not a fan of maintenance, and I certainly try and get every baby off any anticonvulsant before I discharge them, because usually they come back to clinic a month later, still on phenobarbital and didn't really need it. But our maintenance is 5 per kilo. We don't routinely monitor levels, simply because it's a chore and difficult, and they come back after many, many days. I tend to ask for this if I'm giving babies very, very high doses with difficult intractable seizures. I tend to try and get a level to see if I can go even higher with my dose in the ICU. And so really the duration of treatment depends on the underlying cause and likelihood of further seizures. But we would ordinarily stop any anticonvulsant prior to discharge if we possibly can. So we're very reluctant to send a baby home on phenobarbital. EEG. So you either have it or you don't. You either have access to it or you don't. And there's no doubt that the conventional EEG is ordinarily the gold standard for looking at the brainwave activity in any child, infant. But ordinarily what we have at our fingertips on the NICU is amplitude EEG, which actually has been around for 30 or 40 years, but recently become much more popular after we've had therapeutic hypothermia and helping us with the treatment of those babies. It is actually a very useful tool. So I'm just going to mention a little bit about AEEG. Clinical encephalopathy or suspected brain injury. We tend to mostly use it in our babies. We're concerned about an HIE, but also if a baby is having thought to be having seizure activity, we will pop an AEG monitor on as well, but it does have its limitations, and as long as you understand its limitations, it's fine. It's not a replacement for video EEG, a proper video EEG. You can have clinical suspicion, we consider in babies who are abnormal, but I have to say, interpretation in the preterm infant is incredibly difficult. I'll show you why. And so there are various other reasons that people might use AEG, and you would have an idea of what you use yourself. But it's very simple to place the electrodes. It's a highly compressed trace that runs at 6 centimeters an hour. So if you basically have a seizure that's lasting less than 30 seconds, you're not going to see it. And you just need to know that. It has its limitations. It's not fantastic at picking up small, short-lasting, subtle seizures. It just doesn't do that. It's fairly gross, but very helpful. The main feature is the amplitude. It can be used for screening and monitoring, and I'll just show you a couple of how we use it. I don't know whether you use it, but it's a very, very simple tool that I love. Because we have an upper level that needs to be over 10 microvolts, it's a semi-logarithmic scale, and a lower level of the thickest area above 5 microvolts. And you see a slightly wavy pattern, which would be good for a sleep wave cycle, and you see a fairly normal, a nice normal trace. And that's fairly easy, fairly straightforward, and we'll do a bit of this in the workshop. Mildly abnormal, the lower margin simply drops below 5, and you look for the thickest area. It's mostly below 5. We call that moderately abnormal, and then we can look at severely abnormal, where the lower margin is below 5, and the upper margin has dropped below 10. And so you can see here a very low trace. So it goes from normal to moderately to severe. If just knowing those 3 things can be quite helpful. It is a bit more complex than that, but actually that's a pretty good easy. It's all about pattern recognition. And if you look at an EEG, you get a fairly simple trace underneath, and then you can look at a pattern here, and we've got a fairly normal pattern here, then it going down to abnormality here, and then recovering. And I won't tell you at the moment why that's occurred, because we might do some quizzes later on. But I think it would be pretty simple for anybody who's used to seeing AEGs that this is classical seizure activity, where we have a slightly depressed trace going up to seizure, and then you look at the EEG and you can actually see it on the raw EEG here, all the seizure activity. Sometimes it's incredibly easy to interpret, and that's why I do like AEG. But we have inter-observer differentiation. There are artifacts I can show you about when babies are crying, they're having a care, they've ripped out an electrode. This isn't perfect. It can be very confusing. And you can monitor a baby all night and think it's all right, and actually your electrodes have been misplaced, or the impedance is wrong. So it's not always simple. And the other thing, of course, is that depending on your gestational age, depends on what your EEG looks like. And actually, if you look at preterm babies compared to a term baby, they look pretty abnormal all the time. So interpretation is very hard. It is something you need to learn. Mostly I ask people to just simply do this on term infants. The preterm interpretation is very difficult indeed. As I said, that's a useful training website to go and have a look if you want to know a bit more. And so what I would say is, from my point of view, seizures, we look at the ABC. There's a wide differential, and therefore the treatment is very difficult. And I would treat the cause if it's prolonged, and if prolonged, consider the anticonvulsants, and we then have a choice of anticonvulsants that we can use. I do tend to monitor with AEG, but I am very well aware of its limitations and who interprets that. So not an easy area to do, but I hope that was useful to let you know what we do at the Corniche. Thank you.
Thank you, Professor Eason, for this very nice presentation. I think we have not enough time for